Thank you very much, Denise, and I'm very honoured to be here. Thank you to Helen and Sam for putting up with my last-minute slides, sending across. I am very, very privileged to be here. I think I'm going to present a bit of doom and gloom in the slides, but I'll start on a slightly positive note, in that we are very lucky in Nottingham to have the Brill team and people like Dr. Crozier who champion services for people with neurodisability. When I first arrived in NUH 2 years ago, I came from Wales, and there wasn't an equivalent of Brill over there. So I was very intrigued already. And from an adult rehab physician's perspective, you've got to understand when people transition over to us, if they transition over to us, they'll likely just see us in clinic. We don't have a wider team around us often that they might enjoy in pediatrics. And anyone who's ever seen the NUH clinical system will know it's very, very difficult to understand the nuance of what's happened before they've seen us. And you can imagine the experience for the patient is often very, very unsatisfactory. So I emailed Denise, and I remember it very, very vividly. I almost felt like before I'd even hit send, I got a reply immediately saying, we need to meet and we need to discuss. Great. And then I remember meeting Denise in the CDC in a sort of seminar room, and you can imagine, big, broad smile, this beautiful Northern Irish accent. And let's just say I couldn't say no. So we started transitioning clinics from then. It's made my life a lot easier. Now, the way things get configured in the NHS, there's a lot of influencing to be done. Money doesn't exist. So we had to sort of rework some of our existing resources through a spasticity clinic and repackage it as transition. And that's how we've managed to bring our physio, our OT, myself into that clinic. But I think the point is, where there's a will, there's a way. And it just needs clinicians, service providers, and patients themselves to often come together, and things will happen. Now, I don't know, is Rachel Keatley in the room today? Oh, this is from one of her papers, and I was shocked when I read that. 40,000 every year. Now, this will be varying degrees, but I was not expecting that number. And they are certainly, the majority of these will be surviving. I am not sure whether they're ever seeing adult services, and I worry about where these people are, because we know even the mild ABI cases, the needs can be enormous, especially if not dealt with in a systematic way. I think it is fair to say that transition into adult remains very fragmented, and continuity of care is lacking at the best of times. And we experience in this country a very critical transition gap, and this is pretty much reflected in all the guidelines around transition that you see. This isn't a secret to anyone. And if you look at brain tumor survivors, for example, these phenomenal numbers, 70% will report unmet rehabilitation needs. So clearly a lot of improvement that needs to be done. Now, that word rehabilitation needs as adults. So I am a rehab physician, or physical and rehabilitation medicine as it's more popularly known worldwide. We champion rehabilitation services in adults. The UK, when you compare it to the rest of continental Europe, we're just about better than the Irish, and that's about it. If you were an Italian, you will have access 10 times better than you do in the UK. And, I don't mean to be doom and gloom and bleak about this, but we have to be honest where we are at the moment. Now, what is rehabilitation? There is a World Health Organization definition for it. So it defines it as a set of interventions to optimize functioning and reduce disability. The key words are interventions. These are multidisciplinary, spanning from the health sector all the way to the social sector. And it's focused on functioning and disability. So it's goal orientated. I'm not just treating an impairment for the sake of it. There has to be a functional goal at the end of it. And it's just a reminder just to say, this isn't just my business. This is everyone's business. Disability doesn't exist because of an impairment. It exists because of a whole environment as well. Now, this is the World Health Organization International Classification of Functioning. Every rehab trainee gets drilled this into them when they first start. Point is, like the biopsychosocial model, the individual, it's not just about their body structure and functions. It's a much wider set of domains that we're looking at. And as a rehab physician, I can move beyond just the body structure and function and talk about some of the other issues that might be affecting a patient that I might have a bit of an understanding around the legal side of things, and also what the social services available. Now, one of the major criticisms of this is, where is the quality of life? Because we know that none of these domains correlate either with each other or with quality of life. And again, it comes down what is important to that individual, and ultimately all rehab is goal-based. Now, I like to show this slide, and this is pretty much one of the first slides all my trainees get to see as well. And it's just understanding that there is a fundamental basis for our interventions in neurorehabilitation. And the fundamental basis of that comes down to neuroplasticity. So when I have an adult with an acquired brain injury, I know that there's a window where that neuroplasticity, the ability to mold the central nervous system, is highest, but that never goes away. And this idea that, rehabilitation is only for people soon after a brain injury and then it just disappears, that's not true. People can recover and make gains at any point in their journey. Rehabilitation can be appropriate at any point in their journey. Now, this is, you've got two pictures. If you look at the map, so on the left and on the right, this is transcranial magnetic stimulation, cortical mapping. Now, what you can do is you can stimulate parts of the cortex and see which parts of the body respond. You can then apply a rehab intervention and you can redo it. And what you'll find is the map changes. You are fundamentally changing the structure and architecture of the brain in response to rehabilitation interventions. Now, that can be a good thing. It can be a bad thing. And that's where specialism comes into play. You need a skilled therapist who knows what they're doing to make sure that the neuroplasticity that they're inducing is adaptive rather than maladaptive. There's a famous experiment. I don't know if you've heard of Edward Taub. There's a famous animal cruelty charity, very famous in the States, called PETA. They exist because of this gentleman. He was a neuropsychologist. He used to perform some experiments on monkeys. He used to give them lesions or strokes, basically. And they often would come out with paretic arms. But a lot of the work that he did forms the basis of our understanding of neuroplasticity. So, for example, there's the famous the wells and pellets experiment. So what you do is you give a monkey a lesion, paretic arm, and then you have them attempt to get pellets out of wells. And the smaller the wells are, you force them to use finer and finer pincer grip. And what you find is that the smaller the well, the better the monkeys perform. And it's similar principles that we apply in neurorehabilitation in adults as well. Now, this is another principle that we often apply in rehabilitation. What we're trying, and this is more to do with physical rehabilitation, but it does apply to other aspects of rehabilitation as well. What we're trying to do is overload a tissue in order for it to adapt and increase in function. So you get this sort of graph with load and frequency, and this is how we determine rehab dosing. And what we know is that there is a supraphysiological overload zone where if we can exercise or load that person, whether it's task-specific practice, whatever it is, we know that that person will then adapt and gain function afterwards. Now, this is where it gets tricky, because if you don't provide enough load or frequency, you won't get the gains. If you provide too much, you'll end up with tissue failure, rehab fatigue, worse outcomes. Again, this is where your therapists are skilled and they'll know how to approach this. You need experience. You need to have worked with people with ABI over a long period of time to become confident with this. And the other aspect of rehab is around augmenting function. So technology is increasingly becoming focused on this, where we can't overcome a body impairment or problem with anatomy, so we replace it with something else. So on the left there, you've got a microprocessor knee prosthetic that we often use for our limb loss patients. In the middle, you've got an augmentative assistive communication device for those with speech impairments. And on the right, you've got a drop foot stimulator, which stimulates someone to pick their ankle up when they're walking, prevent them from tripping. Now, this is where I get slightly more positive. Okay, so rehabilitation is changing, and it's changing very rapidly in the adult world right before our eyes. The World Health Organization has this 2030 initiative, and it came on the back of a World Health Assembly declaration that happened in 2023, which the UK is a signatory of. And the UK now has certain obligations by 2030 to demonstrate that it is providing rehab. And there's a whole list of indicators that they need to report back with as part of their health service. So it's very much on the agenda. And Denise mentioned the National Rehabilitation Centre. That's why I'm in the Midlands. So yes, we are hoping to open up the building next month. And it is a game changer for rehab in the UK. There are certain things there that have not existed in the NHS before, particularly with things like robotics, neuroplasticity suites, cardiopulmonary exercise testing. This is now bringing us to a level where we should have been a long time ago. These are things that exist in mainland Europe, in the States already. In the UK, we've been far, far behind. Now, there are a number of guidelines, and this again is reflecting how rehabilitation is becoming more and more reflected in literature and guidelines and policy documents that are coming out. And the document on your right only came out this week. So rehabilitation of chronic neurological disorders, including acquired brain injury, definitely worth a read. There's a very heavy focus on key working and case management in there. And I think I might have, yeah. So just a few key points out there that I think are relevant for everyone. Transition, they're asking people to start it very early. Now, with Denise's team, we start from 16 onwards, and really they judge when it's the best time for patients to start meeting us. And we can carry on doing transitions to clinics together for a little while until they transition over. So in Nottingham, we're in a good place when it comes to that. Key workers are complex case managers. Again, this is a resource issue. Where do you find these people from? My personal view is that medics do not make very good case managers or key workers. We naturally tend to over-medicalize issues. But then the question is, where do you get these people from? So we talked about joint pediatric adult clinics, and then electronic rehabilitation plans. So I was very interested to hear the earlier discussion around education plans being a means to deliver neurorehabilitation. NUH's electronic system, as we move into a new EPR system, is God help us all. But again, this is something that the NICE guidelines now explicitly state that people should have. And then recognizing neurodevelopmental stages, not just chronological age. This is where I'm very lucky to have my pediatric colleagues, because I have very limited understanding of these things as an adult physician. So I'll leave you with that. Favorite quote of mine from Confucius: it does not matter how slowly you go, as long as you do not stop. We've got a long, long way to go when it comes to rehabilitation services for acquired brain injury in childhood that then transition into adulthood. But we are making progress. Things are changing. And I hope that in future years we can report back with more and more achievements as they come. My contact details. Thank you very much.